want to thank all the panelists because I think this has been extremely informative. But before we end this discussion, I'd kind of like to get thoughts from all of you relative to what we've discussed. So, Dan, I'm going to start with you.
Okay, yeah, thanks, and thank you all for participating with me. This was a lot of fun, and it's a great opportunity. The field has really now a new option for a phenotype that we'd never treated before effectively. And you know, for us, you know, I think we're excited to see, you know, this unmet need come into focus a little bit more. And we talked about the different phenotypes of prostate cancer, and I think it's important to think of this. We've traditionally thought of it as a single continuum, and it's not. There are multiple pathways in which patients develop lethal prostate cancer, and the M0 space is really one of those that I think is one of the slower ones, and it really needs to be thoughtful, you know, around how we manage, who we manage, and really what the goals are of therapy. I think imaging is overdue in this field, and we're very excited about where it's going. One thing, you know, I think to look for in the future is going to be, you know, image-directed therapies. And we talked a lot about PSMA, and I think, you know, PSMA as a molecular diagnostic, as a therapeutic companion, as a directed therapy, I think holds a lot of promise. We're going to see trials like that in the future. It'll be interesting to see where in this space it falls. But recognize that radiology now is part of the multidisciplinary team. And if it hasn't been in your practice, it needs to be. And we meet with a multidisciplinary team on tumor boards with radiology and pathology regularly. That's academics. You know, we're all in one building. That's easier. It's harder in the community, but it's really worth it to be able to kind of keep up with these changes if you're having that kind of regular discourse.
Yeah, and I think that's a great point. And you know, Phil, you and I had talked about that, and so again, your comments, but specifically also address Dan's comment about this new, potentially burgeoning field of theranostics.
You know, I agree. I think a lot of the advances that we're doing today with PSMA-targeted PET imaging is really opening the door for lutetium-177 PSMA therapies or thorium or actinium-type therapies using alpha particles that have the potential to be another tool, therapeutic tool, in our war chest. And I think this is just the tip of the iceberg. I think it's so exciting to see that we're moving past the idea of if we should image. The questions are now when, how, and what. And these questions are only going to be answered if we all work together. And that's why it's an honor to be here sitting up with this distinguished panel and having the opportunity to just contribute radiology as a tool to help us treat patients better. So I guess a last word of the comment that I'd like to make is, it just echoes what Dan had said, is, you know, I encourage everyone to reach out to your radiologist. Even if you're in a community practice, there is a private practice radiology group that can be your champion when it comes to prostate cancer imaging, and developing a working relationship with them for prostate MRI, PET-CT imaging, CT, everything will do a world of wonders for your patients. And I think it's an opportunity that we have to capitalize on.
Great comment. Alec?
From a very simplistic fashion, just the data from Prosper and from Spartan is incredibly meaningful to our patients. And you know, it's like Dan said earlier, before with these medications, we're talking about extra 4 months of median survival gain. Now we're talking about 20 months metastasis-free survival. That's incredibly meaningful. And it's a very exciting time for us as physicians who treat prostate cancer, and it's an incredibly gratifying time, and for the patients who have prostate cancer. Now I could look at my patients, I could say that there are new medications coming out, and I think we can meaningfully delay your disease onset to metastases by a couple more years. That is just exciting to be a physician at this time.
Neal?
So thanks, Raoul, for organizing the panel. I think, you know, as Phil's saying, you know, theragnostics and the whole notion in the burgeoning field of targeted alpha therapy is incredibly exciting. We didn't get a chance to talk too much about it. Maybe we'd do another panel. Dan mentioned PARPs. They're clearly going to get, at some point, approval in prostate cancer. with a compendium understanding the patients who have DNA repair mechanism defects. We see them approved in breast and ovarian cancer. Oral agents, which will add to the armamentarium of what we already have in an advanced prostate cancer clinic. We think about this, all this excitement now of 2 new agents that could be approved in the M0 case 1 index, whether it's apalutamide and enzalutamide. I suspect it'll be both, changing our options. Just tissue testing, metastatic tissue testing. I do a lot, to understand somatic defects and how to personalize medicine, plus the hereditary prostate cancer issues in germline testing. So why do I say all this? I say all this because for our colleagues who are listening, it's exciting, it's getting a lot more complex and a lot more specialized, and I really think today that advanced prostate cancer really requires a true dedicated specialist to it, whether it's in a multidisciplinary fashion at an academic center or in a clinic like Alec's or mine or Phil's, and so we work together. We have to specialize, and it's probably true of so much of medicine, but it is exciting, and to me, it prevents the concern that I hear a lot of times about burnout. How could you be burned out if you're following all these incredible advances? I know, and I understand that's another panel too.
That's right.
But anyway, thanks for having us.
No, I think your point is that those are great points, and I think because again, as we said, it keeps changing every 3 or 4 months, and hopefully we will sort of move away from this traditional organ-based cancer-driven to something that's more, based upon molecular drivers and treat people N=1 based upon what their tumors are expressing. So thanks all for your contributions to this discussion. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative.